We have a fascinating panel discussion that Retsef Levi is going to lead, and I'm going to ask Retsef to please introduce the panel. You spoke to us early this morning about some of the challenges associated with chronic disease management, and I think that perhaps the panel is going to talk a little bit about how digital innovation might foster delivery system redesign. And I know that we have leadership from 3 states here on the panel, so it should be a dynamic conversation. Retsef, are you ready?
We'll see.
You're ready, I know.
Tell me after the panel is over.
I know you're ready. Okay, thank you.
So thank you, Jay, and thanks for everybody. Good afternoon. I'm going to start with just giving a brief background and then introduce our panelists. And we're going to try to have it as interactive as possible and hopefully leave some time for questions from the audience. So I'm not sure if that's a known fact for everybody. I knew about that fact, but probably the magnitude of that fact was not clear to me until I started to prepare myself for this panel. But the fact of the matter is that state government in the US are responsible for a significant portion of the national healthcare spending through their Medicaid programs. The Medicaid are the programs that were set to take care of children, the poor, and the disabled. And they are administered by the states with support of the government. In addition to that, government in most of the states are essentially one of the biggest employer. So that's another role that they play as spending on healthcare. And it's fair to say that this role has substantially expanded as a result of the Affordable Act in 2011 that essentially let states to opt in to expand their Medicaid services. And at the moment, across the country, Medicaid programs are responsible for about 75 million patients. Most of them are among the older, poorer, and the sicker in the population. So it's fair to say that state governments have a major role in driving innovation around value-based payment schemes and healthcare system reform. And we brought together today 3 very senior and veterans in that space. 3 people that represent perhaps 3 of the most advanced states in the country, both in terms of what they currently do in that space, in terms of payment reform and healthcare system reform, as well as in terms of what they aspire to do and their attention that they put into those issues. And it's a delight to have today Jason Helgerson, the Medicaid Director of the State of New York, Department of Health, Daniel Tsai, the Assistant Secretary of the MassHealth and the Medicaid Director for the Commonwealth of Massachusetts, and Michael Wilkening, Undersecretary of the California Health and Human Services. Each one of them, I'm not going to go into the details of their bio, but they are veterans, seasoned, with a huge responsibility in their respective states. And I think it's going to be exciting to hear how they view the current state and the future state of their own states and maybe beyond. So I prepared a set of topics. We're probably not going to have time to discuss all of them, but hopefully we'll touch upon some major issues. And I wanted to start with the topic of innovation of payment schemes and reforming health systems. So we are all exposed to the public debate and to the expert debate about the imperative to move from and change fundamentally the way we pay for healthcare, specifically moving from fee-for-service schemes to value-based schemes. And it's also fair to say that actually Medicaid programs for a long period of time by now have employed and still employing managed care approaches to healthcare services purchasing, and maybe are perhaps in the best position to lead that change. And indeed, reforming the payment schemes is at the focus of most states at the moment. What I would like to ask the panel members is to reflect on where each one of their states stand currently on the journey to reform payment schemes. But maybe more interestingly, also reflect on what states they are on reforming the health systems in their states. And if I may ask, try to make it personal for the audience and really try to highlight what these reforms mean to citizens that are using the systems, to providers that are part of the system, and to the public as a whole. So it's going to become concrete to everybody. And I want to start with we are known for our hospitality here in Boston, so I'm going to start with the person that had to travel the longest distance, Michael.
Great. Thank you very much, and thank you all for having me here today. I'm Mike Wilkening, Undersecretary of the California Health and Human Services Agency. Just by way of background for our Medicaid program, which is Medi-Cal, we have 14 million people in Medi-Cal in the state of California. It's about a third of our population, with an annual budget around $100 billion, including the spend from the federal government. We were one of the first states to go into managed care and have really been making a push to get more and more people enrolled in managed care in the state. And right now, about 80% of our beneficiaries are in a managed care environment. And we continue to push more services into the managed care environment. I'd say that over the last several years, the things that we've been focused on in California is both increasing the services that we have in the managed care environment, so making the managed care plans responsible for more of the person's overall care, integrating other services beyond just health services, so looking at behavioral health as well as social services, and most recently shifting into more of a patient-centered view of our program. So with our Medi-Cal 2020 waiver, which is the last waiver we got from the federal government, an 1115 waiver, we're focused more on driving incentive payments towards our designated public hospitals that focus on value, so focus on getting people out of hospitals and out of inpatient care, focusing on preventative care, focusing on outpatient primary care, and also with integrating the behavioral health system with our health system. And we have a whole person care pilot that we have as part of that waiver, where we're providing payments to counties to take into account social services, behavioral health, and incorporate all of those components together to really make sure that we're focused on how to really treat the person as a whole person rather than just focusing particularly on the health components of their needs.
Okay. Jason.
So just a little background on New York. New York is the second largest program in the country. We serve 6.6 million people with an annual budget of $68 billion. And where we are in the sort of transformation process is that back in 2014, after a number of years of trying to make the Medicaid program in New York financially sustainable, and we achieved success in terms of bending the cost curve and reducing our expenditures on a per recipient basis by pretty substantial amounts, we came to the conclusion and then finalized the negotiation for a waiver with the federal government to acknowledge the fact that at the end of the day, Medicaid is but one payer in purchasing services from a delivery system that inherently is inefficient. And that no one else was positioned to actually help drive the delivery system towards a more cost-effective plane than ultimately the largest purchaser, which is the Medicaid program, and the responsibility really did fall to the state to play that leadership role. And the waiver we negotiated, our delivery system reform incentive payment program, $7 billion investment of new money into our system to try to drive organizations across the spectrum to come together in integrated delivery systems to collaborate in ways that will lead to better outcomes and lower overall costs. That effort is about halfway through, and we've seen some positive results in terms of reductions in avoidable hospital use, including ER and admissions and readmissions. But there's still quite a bit of work trying to get this very large and complex sector of our economy to try to work together in more of a collaborative way. We talk about trying to make healthcare a team sport, which you get to your point about the patient experience. I sometimes say the challenge in healthcare is it's probably one of the least customer-friendly sectors of our economy. The only one sector that I can think of that's comparable is education. Is where, I mean, if you think about it, much of the onus is on the patient to go and get care, regardless of how complex, sick, disabled they may be. Services are offered at the convenience of the provider, not at the convenience of whether you think of them as customers, patients, members, you name it. And I think at the end of the day, if we're going to be successful in making this thing we called healthcare affordable and effective that meets the needs of an aging population, and with growing needs, we have to make it more responsive and more centered around the individual than it is around the provider. Last thing I'd say, we are big believers in the move to value-based payment. We are on a path that by the end of the decade, 80% of our payments to providers will be value-based. And that's not pay for performance. That is providers taking on risk. And that's a $60 billion enterprise, so billions of dollars moving into risk arrangements. So far, we're at almost 40% of those reimbursements, but we have a ways to go. And we believe at the end of the day, you need a combination of both delivery system reform and payment reform in order to hopefully get to a point where we're talking about radically improved outcomes at very affordable prices. So.
Thank you. Dan.
So similar context in Massachusetts, but some factoids that always set the context a little bit. From a cost standpoint, it's not the only thing, but it's a real thing when you're running a public sector payer and have a fixed appropriation per year. MassHealth and Medicaid program here in Massachusetts, we cover just shy of 30% of lives in the state. We account for 40% of the state budget. And we are growing at a significant multiple each year versus what state revenue is growing at. So you don't have to do a lot of weighted average math to figure out you quickly outstrip what the budget provides each year. And for the Massachusetts Medicaid program, which is one of the most robust from a benefits and coverage standpoint in the country, but the fundamental structure of it hasn't really changed in 20, 25 years. We were an early adopter of managed care, where we have health plans working with us, but underneath all of those contracts, you still have providers being paid on a volume-based fee-for-service context. So two factoids to make this real. One, from a data standpoint, if you look at our high and low-cost providers, even if you take a population that is at the same risk stratification, one particular provider is 30% more cost-effective on a total cost of care basis than the other, same risk population. When you look category of service by category of service, the biggest, you can almost say, the high-cost provider has a 30% higher usage of specialists and hospital-based care. The lower-cost provider has 30% less of that, but almost a 30% increase off a smaller base of primary care, clinic-based visits. So very, very different practice variation that we see here in the Commonwealth today, driving massively different cost outcomes. The other component from a member experience standpoint, so the Medicaid population, I mean, there are many elements similar to what commercial Medicare would be, but there are also months where we're either the only payer for some of the long-term care benefits and or for some of the folks that are the most vulnerable in the Commonwealth from a mental health, behavioral health standpoint we have. So we're in the midst of moving towards full ACO accountable care at-risk adoption. Starting March 1, we'll have 80% of our lives in fully capitated models with accountable care organizations, 17 of them across the state. But in one of the pilot models that we rolled out, we found one of these, a community health center-based ACO, took a look at the data we gave and looked at their 4 highest cost members. 2 of them were at a homeless shelter next to a fire department. The homeless shelter offered breakfast and dinner, but no lunch. So on a daily basis, those 2 individuals were going to the fire department complaining of chest pains, being taken in an ambulance to the local hospital, getting a full workup, getting lunch, and going back to the homeless shelter in the evening for dinner. 2 other individuals were women who during each month, because they didn't have access to sanitary pads, were showing up in the emergency department for that. For the first time looking at data with the ACOs, you see those 4 cases. I mean, that's about as clear-cut as it gets. It's terrible from a cost standpoint. It's terrible from a quality of care member customer experience standpoint. it's terrible from a health outcome standpoint. There must be a better way we can think about structuring the care delivery system and payments to get at that. So that's part of what we're trying to do through moving to new value-based payment structures.
So, thank you. So, I don't know if I mentioned that, but I was born in Israel, and we tend to be a bit provocative, so excuse me for the following question in advance. So I have to say, I hear all of you using the term value-based care and outcomes, and I just want to ask you, what exactly do you mean by value-based care and outcomes? What does it really mean concretely? So if I'm a healthcare system and I want to move to a value-based care and a patient-centric, what does it really mean? Do we even have a consensus about what do we envision when we use those terms?
So when we're talking about it, especially as I was talking about our 2020 waiver, we're looking to shift from hospital-based care, inpatient, having more preventative care, more outpatient care, so that people aren't having to go into the hospital as often, we aren't having admissions that we don't need to have, that we're focused on the integrating other services, so behavioral health and social services that provide those other types of services you need to keep people from coming into the hospital and provide the service in the least restrictive or least cumbersome method for the people.
Okay, thanks.
So the way I'd answer it, I think it's a great question, because value-based payments, like one of those terms in healthcare, patient-centered is another one. People throw them around all the time, and it kind of means something different to everybody. So in the case of value-based payment in New York, we were obligated under the terms of our waiver to move to value-based payment, but basically we were directed to develop a roadmap that would describe what value-based payment meant in the New York context and the path with which we would get there, and then CMS would approve that document. So instead of us behind closed doors in a government office building doing that, we decided to engage the stakeholder community in New York in a very comprehensive way. We convened 14 committees, 600 plus individuals from across the spectrum, from clinicians to patient advocates to members to insurers, a wide array of providers of all different types to come together. And we went through a very methodical process to really identify what populations are we talking about for the different types of value-based payment arrangements, what measures, what are really the outcomes we want for those different types of services or populations, and then what do we mean by the different types of value-based arrangements? What do we mean by risk? How much risk is appropriate? How should those contracts be structured? And out of that collective process came the roadmap, which is available on our website. It's an 80-page document in case you're having a hard time sleeping tonight, that lays it out, I think, in pretty good detail. But I think the other lesson we learned, or we heard loud and clear from our stakeholders, and CMS agreed with us on this as well, is that roadmap needs to be updated every year. Because I think one of the challenges we have in measuring value is that the measures we have used historically, which tend to be these claims-based, HEDIS-like measures, are far from ideal. They're mostly process-based. They don't really tell you about the outcome. We need to evolve away from them, but right now, at least, in many cases, they're the best that we have. And I think there's a big acknowledgement at the end of the day, and Dan was mentioning it, that we need to look at the social determinants of health. We need to look at measures of the quality of life of individuals. We heard this morning about the power of PROS measures within the Kaiser system. I think there's other measures that are coming along that will come, and we are envisioning that our measure sets, how we define value, is going to evolve with that.
Did you also ask patients about that?
Yes, so we involved patients and members in different types of contexts, including individuals also who represent large groups of patients and such, but absolutely they have to be part of that.
Dan, any thoughts about this?
Yeah, I think moving to a new payment model, which I'll define in a sec, I think of it as a necessary, absolutely necessary, but not sufficient condition to actually get the delivery system to improve in the way that you want it to, that we want it to. When I was at McKinsey, I remember working with one particular hospital, and we looked at a readmissions prevention program through more care management outside of the four walls of a hospital, engaging individuals and keeping them from coming back. And it ended up being a program that financially did not make sense because you'd invest in stuff that you don't go paid for today on a fee-for-service basis, and you actually decrease your heads and beds and decrease your revenue, so your contribution margin goes down. You're in the exact opposite cycle of what you think about for for good member care. So moving out of a model where you're paying based on the widgets and such to paying a budget for a total cost of care risk adjusted for the population, I think is a prerequisite in order for all the things we'd like to think about that should happen within healthcare delivery to happen. But the other component is how you actually get care to be integrated. And especially in a state like Massachusetts, we are a highly hospital-dominated system. One of our early pilots into value-based payment structures was the state, I was not here at the point, several years back, called a patient-centered medical home, oriented around primary care with some shared savings incentives for the primary care docs. What we found when we took a look at evaluating that program is you had primary care docs, probably underpaid, wanting to do all the right things, but having no leverage in actually figuring out how to work with specialists in hospitals in rejiggering workflows to have all the things that you would like to see happen. And so what they ended up focusing on was stuff that they could actually control, like individual HEDIS quality metrics on colonoscopy screenings and things of that sort, which is, don't get me wrong, that's like good stuff, but you're not getting at things that require providers fundamentally to completely change their workflows and how different folks start to integrate. So a payment model, just changing to an at-risk model, does not solve things of that sort. So Massachusetts, the accountable care model we rolled out had a bunch of carrots and sticks with that. We defined 3 at-risk models. Almost all of our ACOs are going into a fully capitated model that we pay on a per member per month risk-adjusted number. All the new dollars we negotiate with the feds, $1.8 billion of new funding over 5 years, the way we kind of rebalanced the hospital primary care calculus was we said the new dollars follow lives in primary care practices. So ACOs coming together were essentially trying to, it was like watching speed dating happen. They were all courting the different health centers and primary care practices because the funding for new infrastructure was following kind of primary care-based lives. And then we have a lot of requirements of the contract to get the funding where you actually have to have different parts of the health system coming together. So those are some of the things where I guess the point there is that you can design the perfect risk-adjusted payment model, change the way cash flow moves completely across the system, but have nothing actually translate through to the way individuals experience care.
So let me follow with that with another somewhat provocative question. So veterans of the healthcare industry look at what is happening now with maybe a slightly cynical eyes and saying, basically what we see here is another attempt to impose capitation on the market. We've tried that. What makes us believe that this new pressure on the system will really lead to the transformational change that we need and not to another attempt to tweak around the edges? Because I think if you look on the economics of what is happening in terms of the number of chronic patients, the older aging population, a marginal change is not going to be sufficient. So how confident you are that the strategies that your states are employing at the moment are sufficient to drive transformational change versus still has some serious risks of maybe staying still around the edges?
I'd love to say that I'm completely confident that it's going to work. I'd be lying if I did. I think there's a lot of promise in it. I think that if we're setting up the right incentive structures, getting the right people together, and that we're focused on providing patient care to people in their least restrictive environments and building up those supports around them, that's going to lead to better outcomes for people, and it should do so at a lower cost. But it does require a lot of different players coming together and trying to figure out how to set up those incentive structures such that everybody's moving in the same direction and you don't leave somebody vulnerable so that they can take advantage of what the others are doing. We found this. We did the Coordinated Care Initiative in 2012, which was taking our persons with seniors and persons with disabilities, so dual eligibles, Medicare, Medi-Cal, and trying to bring all of that together under a managed care environment, same managed care plan, providing both of those, and also incorporating the long-term services and supports. we ran into lots of problems with it. We had an opt-out provision in it. Lots of people opted out. You found the doctors were telling people, don't go into this because I'm not part of that, and I'm your doctor. You don't want to lose me, so opt out. We found that one of the things that we were trying to do is who's saving money, and a lot of the money being saved was at the federal government level, but the federal government won't share in the savings associated with Medicare. So you aren't going to get that incentive structure going. So those are the types of things that I think we continue to try to grapple with as we reform the system. But I do think that moving towards that patient-centered model where you can really start thinking about what are the different factors that are causing the problems rather than dealing with it in the hospital is going to lead to better outcomes and savings in the system overall.
Dan?
Oh, we're going out of order, okay.
Yeah, I need to keep you alert, right?
Yeah, I'll stay away. So we will not have success with all 17 ACOs. And in my mind, I think there is significant risk, but there's no other choice but for us to move in this direction. Because, from a practical standpoint, if we didn't start to do some of these things, which we built into our pricing and built savings in, we'd be looking immediately at cutting rates, cutting benefits, cutting eligibility to manage the Medicaid program. So there is no choice but to kind of go down this path. I do not expect through this 5-year period that all 17 ACOs will be equally successful. Indeed, in the contract negotiations we did this summer, I was shocked by, we saw a huge amount of variation in the sophistication of the entities we were working with, even to really understand when they were negotiating rates with us at a granular level, who was actually driving costs, what was driving costs, and what were the quality performance metrics. So I think we are taking the relatively hands-on approach where it's not just putting a payment model, handing the keys over. There's pretty active contract management that is happening on what we want to see actually happen. I think that's the only way you can manage it from a Medicaid program. You got to get the contract, the payment model right. You need to have a vision and desire for where you want the delivery system to be. You can have to articulate that to your providers and contract manage to ensure that folks are moving down that path. And I expect we're going to have some folks who are not going to be able to financially sustain and make the improvements necessary across all 5 years of the program. Some will drop out, but I think that is the right bar to set things at. If we set it so that we knew every single ACO would succeed without doubt, no matter what, you probably set the bar far too low on that.
Okay, thanks.
So our structure is extremely similar to the Massachusetts structure where we have 25, we call them performing provider systems, but ACO-like entities, and I agree that not all 25 will achieve equal success, although I do believe that they'll all achieve a base level of success, at least because we're halfway through the waiver period. But what I would say is the difference between what we're trying to do now than maybe what we tried to do when managed care first came to fore is we're trying to say that at the end of the day that the incentive alignment that needs to occur has to go all the way down to the frontline provider. We cannot have a situation where frontline providers' economic future is based on efficiency metrics like RVUs and those types of reimbursement models. We have to get out of that. We have to link reimbursement to frontline providers more to the outcomes of their patients if we want to actually have that be the ultimate outcomes that we achieve. I think that the challenge with moving away from fee-for-service, and it's going to be fits and starts, and it's not going to be something that we just flip a switch and it happens, but it's so endemic into the system, and the system is so large and complex and it's all these processes have been built around it. But I think the ultimate vision, this is when I talk to particularly the frontline providers of what the potential value or the benefits from value-based payment are, is that if you think of almost any hospital system in the country, they have a unit of people who do revenue cycle maximization. Their entire job is to make sure that when they code for the service they provide, they're coding as high as they can to maximize their fee-for-service reimbursement. Our vision for the future is that those resources, the individuals, the work, the effort, the money that goes into that kind of work ends. And what happens is we now focus those efforts on managing the health of the population. If we can just accomplish that, if we can redirect those resources to better manage the needs and use that to, help navigate the service array for, our most needy patients and introduce community health workers who can knock on doors and really help to connect in communities all across this country, I think that potentially would be a great, powerful, different way to provide healthcare. And I think only way you get there, however, is by value-based payment. But I think it's not just enough for the CEOs of organizations to understand the incentive. If they don't change how they reimburse their employees, the people in the front lines of the system, we're not going to get the change we need.
Yeah, go ahead.
Add one thing to Jason's. I think, let's say for a sec, a bunch of us estates, which many of us are all doing, get the payment structures, the necessary but not sufficient condition, into a place where it makes sense to do this sort of stuff that we're talking about. I think the question then to our providers, to the community, to all of you, et cetera, is where does the innovation come from to figure out how instead of innovation equaling a 25% increase in the cost of care, which is typically what the world we're dealing with in some cases, folks are figuring out how to fundamentally, through the use of technology, member engagement, completely rethinking workflows across different silos of the system and how you structure care end to end, where you're actually finding a way to decrease the cost of care 10, 20, 30, 40%. I'm not saying we can actually get there, but that sort of big picture thinking, now that if the financials are set up to incent that and to support that, that's now an interesting basis of competition for folks really being able to deliver on that and deliver a better member and consumer experience. As Jason, healthcare is probably the most complex, non-consumer friendly sector, maybe besides education, some places that one can think about. And so that's a challenge to you all and to our system.
So that's a good segue to the next topic I would like to hear your thoughts on. And you mentioned it already. It has to do with the chronic patients and behavioral health. I mean, we heard throughout the day the magnitude of the challenge that the chronic patients are posing currently on the system, and it's just going to get worse. Just to state a few facts, the obesity rate currently is over a third of adults are obese, and actually over 17% of kids, young people, are obese. These people cost to the system about 85% of the overall spending. And it's very clear that many of these chronic conditions are highly curable, but highly dependent on the behavior and lifestyle decisions that individual patients are making. And I think that in all the payment and health system reforms that you mentioned in your own states, I think that the issue of behavioral health is a very primary one. But I see somewhat a contradictory trend, if I may say, that at the same time that there is a higher expectation or increasingly higher expectations from the health system to incorporate behavioral health services into the overall care, at the same time many states actually cut back on many other services, perhaps outside Medicaid, like psychiatric beds, like other behavioral health services, like shelters for homeless. And I wonder if you are aware of that, if you acknowledge that that contradiction may exist, and maybe more generally, what is the strategy that you have in your own states around chronic conditions and behavioral health in particular, both in the context of Medicaid, but maybe more broadly in the context of the state? So
in California, and I'll go to the ones who have or perhaps some of our severest needs. We have state hospitals in California, and part of their responsibility is providing restoration services for people who are charged with a felony and are deemed incompetent to stand trial. And so we currently have a wait list of over 800 people trying to get into the state hospital system so that we can restore their competence so they can participate in their own defense. Now, these are people that I would expect. California expanded Medicaid, so basically all of them should be, just about all of them should be eligible for Medicaid. And So as I'm going through this problem, it's something we've been working on for a couple of years now, trying to figure out how to address this population. And just data alone on these people is really difficult to get. And it's two departments that are under my purview. The Department of State Hospitals and the Department of Healthcare Services are both under the Health and Human Services Agency. And getting the data matches between those two departments to figure out what's going on with these people. So, are they Medicaid enrolled? And if they're Medicaid enrolled, what services are they receiving? And these are people that, as we've gone through this process, I'm now about 50% of them have more than 15 interactions with the criminal justice system before they become a felony IST. So this is 15 touch points at the local level, at least, where we should be recognizing that there are needs here, where we should be doing interventions, where we should be figuring out how to bring care around this person so that they don't continue to offend.
You don't need machine learning to recognize that.
Right, yeah, you don't need machine learning for this. However, getting that data match is really difficult. And so what we found out from just the sample that we did was that about 50% of them didn't receive any Medicaid reimbursed services 6 months prior to the offense that led to the felony IST, which we're right now struggling with how can that possibly be the case and what do we do about it. But just getting that sort of entry information to get insights into the population that you're dealing with is extremely difficult, at least at the state level. I think at the health plan level, they've got a little bit better information about their particular patients, as you were hearing from Kaiser earlier today. And that's a group that we've been working with to try to figure out more about their electronic health records and the insights that they get from them. But we do have these people that are touching multiple areas. I'll tell you the other bad secret about it all, and people from the public sector gasp when I say this, and people from the government sector go, yeah. I've been Undersecretary for 8 years. And at the beginning of my tenure, we were trying to figure out, we were doing huge budget cuts in California, and we were trying to figure out what impact we were having on families. And so you're hitting Medicaid, you're hitting TANF, you're hitting in-home supportive services, developmental services. And so the secretary was asking me, well, what's the cumulative impact on a family? And I said, we don't know. On average, I can tell you what a Medicaid family looks like, and then that means that they're probably getting this in TANF and they're getting this in in-home supportive services. But I can't tell you definitively what this means, how many people are receiving the multiple services, and still can't. I have researchers working with me right now to try to get us that snapshot picture, just a simple Venn diagram of how does this all line up, how many people are getting 5 services. And so it's in that environment that then we're trying to figure out how do we incorporate all of these things around people. And I do think that the data aspect of this is going to be one of the difficult aspects for us in trying to shift to a patient-centered focus, especially across multiple departments, multiple programs, and trying to really figure out what impact we're having on a person from any particular intervention across these various programs.
So I'd say sort of 3 things. First and foremost is integration. We have in this country and in some places, New York in particular, treated the mind and the body as if they were 2 completely separate, independent things with and very little sort of coming together of the 2 worlds and the 2 care systems that meet those needs. And so one of our efforts, and it's happening in all 25 of our ACO-like entities, is integrating those services. Co-location, not just co-location where it's like parallel play, where the providers are in the same building, but they don't actually talk to each other, but actually specific models designed to really try to get those organizations to see the holistic needs of the individual, to create a one-stop shop so people don't have to go for one day for a physical appointment, another day for the behavioral appointment. So that's sort of strategy number 1. Strategy number 2 is for those with significant behavioral health needs, they need high-touch care management services. They need organizations who are culturally, linguistically competent, based in their communities, who can help them navigate the complex system, not just from a healthcare standpoint, but also from a social determinants of health standpoint, to really help them to think about what they can do to and assist them in terms of finding and getting into the sort of care systems that they need and supporting them in a journey, which is a journey to recovery, which can be very much fraught with challenge. And the last thing I'd say, and one of the more exciting, I think, emerging strategies is peer supports. Peer specialists are individuals who are trained to support and assist people on the path to recovery, but they are also individuals who themselves are on a path to recovery. We have found in a number of different instances that peers are far more effective than your most trained clinicians in relating to individuals who, like themselves, have been faced with significant and persistent mental illness, substance abuse, or both. And I think systematically we have to find a way to identify and train these individuals. We also know that people with significant persistent mental illness far more likely to be unemployed. In our case, a recent study found that 80% of individuals with significant persistent mental illness were not working, yet we know that when they do find employment, we can actually really improve their health as well as their physical and behavioral health. So I think it's an exciting opportunity, and emerging thought is how do we engage these people who have gone through this path to give them the training, give them an employment opportunity to really help others along a similar path. So those are really the three things we're working on.
Dan, any additional thoughts?
I mean, I think we're looking at pretty similar to Jason in New York, but briefly rates. So we put in about $60 billion over the past 2 years per year of rate enhancement for behavioral health services and providers, recognizing that that sector needs some more investment. Second, from an integration standpoint, the ACO model has behavioral health fully rolled into it. In addition, we've procured for these, what we call community partners, behavioral health providers in the community who have to be able to partner with the ACOs. Of the $1.8 billion, excuse me, new federal funding we got, $400 million of that goes directly to those behavioral health community partners to integrate much more. And third, which is a big priority for the governor here, substance use disorder, opioids. Major focus. We've expanded we got a federal waiver to expand the Medicaid benefit on that to really help folks through the entire pathway to residential recovery and such. And that's a very big area of focus as well.
So thanks. So that moves us maybe to the next topic and has to do with digital health and ecosystem innovation. So digital health is a buzzword, another buzzword, that represents for many the way to transform the health systems in the US and maybe more generally globally. In fact, I'm pretty sure that many of the people in the audience today are at the moment or plan to be soon part of entrepreneurial efforts related to digital health. And in fact, you coming from 3 states, fair to say that these are maybe the 3 largest hubs of innovation around digital health and more generally healthcare. That said, let me raise some doubts about the concept. First, I would like to note that I believe that there is some confusion or at least lack of consistency about what people define to be digital health. But let me, instead of just expressing my own opinion, relate to a very recent article from the Wall Street Journal from November 11th this year, written by a very seasoned expert, Ezekiel Emmanuel, who was, he's a trained physician, and in fact, an academic, but also a former advisor to the Obama administration around healthcare policy. And he wrote a piece in the Wall Street Journal where he actually called digital health a hype, and in fact suggests that at the end of the day, not only that there is an evidence that digital health solution at the moment brings or leads to behavioral changes in how people behave, but in fact there is maybe an increasing evidence that they don't. And again, I want to connect this to our previous discussion where we talked about behavioral health services, and you all focused on very good efforts around how we bring behavioral health services to the community. But actually, when you think about lifestyle decisions and what impact our life environment, it has to do more than just behavioral services. It has to do with what we have to eat, with how our education system looks like. And I know that by saying that, I'm maybe raising the scope of the problem to something very frightening, but it is what it is. So my question to you is, what are your reactions to this criticism? What digital health means to you? What is your personal experience in your state and beyond regarding its promise? What would it take to make it successful? And if your states have specific strategy around digital health? So, Michael.
I actually think that it depends on what we're talking about. So I think, in the presentation by Don from Kaiser earlier, where he was showing the different apps that are out there, and if it doesn't actually change people's behavior, if it isn't engaging, it's just not going to do it. It's going to be just more technology, and you aren't going to get any real benefit associated with it. You're going to, in fact, probably just drive up some costs at some level. We are finding that things like telehealth are starting to help in California, especially in areas, rural areas where we're having problems getting access to people, to specialists. That if you can use telehealth to do that, I think there's promise in actually providing access to those services where people may have to drive 200 miles to get access to a specialist. And if you can instead set up a situation where they can be in their community and have access to that remotely, then I think that has potential, and we're starting to see it. Things like health information exchange. We in California, mainly through the federal government, have spent in excess of $1 billion on health information exchange, and we're starting to see some promise out of that, where health information is being exchanged between systems. Not nearly enough, given the investment that we've made. In fact, we tried to activate one of the systems when we had the fires in October, and just couldn't get it to work. We couldn't get the system to come up to actually provide us with the throughput to provide the information between the different clinical settings to make sure that we had information about people that were coming into the hospitals. But I think that there's some promise there. We have pilot programs where we're in the ambulance taking down the information and then transmitting that to the hospital en route, so that when the patient gets there, they have the information. They don't have to rerun tests. They don't wonder about what's been going on inside the ambulance. So I do think that there's promise here, but I think there's also a lot of overhype as to what you can expect out of technology just from technology. And I do think that unless it's engaging of people or it's fundamentally changing something that's broken in the system, that it's in all likelihood just going to add more layers and more costs onto it.
Dan, any thoughts?
I think I would say marginal things at best is what I've seen on the provider side. So provider and consumer, remember, on the provider side, I think there's clear opportunity, both for how providers manage population health, connectivity. There's a ton of HIT, digital health stuff that could and should develop there. I think we're still in nascent stages on that. On the consumer side, especially for the Medicaid population, when you think of our most complex, highest cost individuals, the things that we're worried about and working with, it's less like an app will help you address that. You got to make sure someone has like housing and food before they figure some of those other things out. So I certainly would be really excited to see if there were consumer engagement, digital health tools that actually helped on some of those things. I don't know what that would look like. I'll be skeptical until I see it. But I think of it quite differently between the provider and consumer side, and then the Medicaid population versus, the commercial population, for example.
Jason?
Yeah, I mean, I would just say that I think healthcare is like light years behind other aspects of our economy in terms of how technology has transformed it. I would say that most of healthcare, the core models of it, are still us as a healthcare consumer going to a place to receive a service at the convenience of that location, And I think that model, while it may work for the healthy and wealthy in our community, doesn't work real well for the sick and the poor, who live very complex lives and for whom that is a very inconvenient way to access vital services. And I think that if we ultimately want the system to be more cost effective, we have to find ways to harness technology. And I would agree that it hasn't been a panacea to date, and not to say that it's going to be a pure panacea, but it has to be part, I think, of the solution. The example I give is just if you compare, not to say that retail and healthcare are the same, but can you imagine, we still in healthcare talk about after-hour care as if it's some innovation. In retail, can you imagine if Amazon shut its website down at 5:01 on Friday and flashed up on its thing and said, call 911 to receive this service from our competitor, pay 3 to 4 times as much, or wait for us until 8:01 on Monday morning. That is our healthcare system, ladies and gentlemen. It is that which, if you call any primary care office after the office hours, that is the message you get. And I think at the end of the day, we have to find ways to harness the power of technology to redesign the models of care, not that they are ends in and of themselves, but they are a means to transform the delivery system. And I think, and Dan made a good point earlier, which is value-based payment doesn't change healthcare delivery. It creates a new environment, a financial construct within which innovation can occur. But I think, and that's why I was so pleased to come to this conference, is at the end of the day, we need new systems of care, alternative ways, and I think technology can be part of that. But we need really creative, innovative entrepreneurs and researchers to really help come up with those new models so that in a value-based arrangements, they can be tried and hopefully be successful.
So that's great. That connects to the last question. That I would like to ask you, and I would maybe ask that you will try to be brief in the answer, so we leave at least room for a few questions from the audience. But you mentioned the ecosystem and the ecosystem of innovation, and as I mentioned before, you come from states that have quite an evolved ecosystem. That is not only a potential to improve the health system in the state, but potentially also an economic growth driver for the economy of your states. To what extent, as a states, you have a strategy and to promote, cultivate, and be part of that innovation ecosystem?
So I think that there's different aspects there. You have we do in California. Obviously, we've got Silicon Valley. We have very innovative portions of our economy. We have other places that aren't as much, and the healthcare system, I think, would be one of those in some regards. Although you've seen, Kaiser's doing some amazing things, and we do have other systems that are doing that as well. I think that it's, for us, a lot of the things in healthcare is really changing that focus, and I think that a lot of it's a cultural issue and trying to rethink how to provide the care and getting people together who haven't traditionally worked very much together, especially in the Medicaid population, where you are dealing with people that a large portion have issues as simple as housing. And if you can't fix the housing issue, it's really difficult to build supportive services around somebody. Where are you going to find them? If they're on medication, how do you make sure that they're following the medication protocols? So, the innovations that I think we really need to be focused on are changing the cultural aspects of this and how we think about providing the care and how we think about relating to each other and how we provide that information across these systems. And it's really basic things like food, shelter, and if you can't provide those things for somebody, trying to figure out all of these other things around their medical care, it's really driving at the last piece of it. All of these other things manifest and it leads to a health outcome. If you can't address those core things at the beginning around their housing situation, food, their mental health issues, substance use disorder, then yes, you're going to treat them in the most expensive and worst way possible for a patient, which is them showing up in the ER and then getting them back out and not being able to follow up, and then you're going to see them again and again. So it's really driving changes in those sorts of interactions and the innovations associated with both culturally and technologically with integrating those different aspects together.
Sure. Dan, any thoughts?
Changing the basis of success so that it makes sense for folks to actually innovate and compete to win, I'll use those terms, by innovating both on the care delivery model side and digital, all those things. So I think we will be successful as a state if it successfully create a very different framework for what it means to think about all these things we just talked about.
Yeah, the only thing I'd say is I don't think we've probably done enough in New York I think it sort of happens, and we haven't focused enough on sort of the new innovative models and encouraged it enough directly. I think one of the things that we are trying to do within our waiver program is trying to connect some of these ACO-like entities to research organizations so that they can actually evaluate all the things that are being tried out there. I mean, part of our challenge is that the scope of this $7 billion investment in, it's like seed capital for a delivery system in the future. Well, they're trying so many things simultaneously. There isn't enough analytical capacity, research capacity to sort of evaluate them all. So my fear is we're going to miss out on an opportunity to sort of really fully understand what worked and what didn't. We'll see the overall performance, but we won't necessarily it'll be hard to sort of peel back the onion to really understand it. But I think at the end of the day, I think this is where the private sector and the research community can come together. I think we desperately need new models. I spent some time really talking to like venture capital, private equity, which we got a good amount in New York, that we really need them to be looking for new companies, new ideas that really can test the status quo of the healthcare system. I think that's really, I think, at the core what we need, because I think that's really where the public sector or private sector could come. I don't think the government's going to come up with those models. I think we have to create the environment from a policy and payment standpoint to allow those models to flourish when they're successful. But at the end of the day, that's really where the private sector needs to come in.
Okay, so with that, I want to open it for the audience questions. We here in the middle.
Raise your hand.
What is that?
It's the mic.
That's cool.
It's MIT here, right? So.
Right.
So I'm actually from the private sector. I work for a large medical device company, and we have come up with a number of technologies that actually, change how care should be delivered and the cost of care overall. But we can't bring the payer and the provider to the same table with the patients to embrace a new care model. We've actually found it's easier to go outside the United States to places with fully integrated payer-provider systems like the UK that have health technology assessment boards that can say, look, we are going to implement this technology because the providers don't want to do it because it would disrupt fee-for-service, even though we're decreasing the cost of care, and the insurers don't care because they're happy doing population health management. They're not interested in trying to change a single segment of care based on a device that's made by a company whose interest is profit.
Any reactions, guys?
I mean, I think that's a good example of one of the problems in fee-for-service, which is that as long as people providers are better off in a fee-for-service environment, things that lower total cost of care, reduce the number of procedures, the number of things that need to get done, it's going to discourage that kind of innovation. And I think it's also a challenge in a multi-payer world. I mean, we have to be honest that multi-payer healthcare has negative consequences, which is it does make for innovators, for entrepreneurs, for new development, it makes the task of bringing your new innovation to market more complex in the sense that you got lots of different payers to deal with to try to convince that yours is the right market. But I think at the end of the day, I think that there's a move to value-based payment that's happening nationwide. I think that that's the future. So I think there'll be more reward for those kind of innovations. It's probably less of an issue with Medicaid because things like knees, hips, and such are less of an issue for us. But I do think that at the end of the day, if we change the payment environment and the regulatory environment, which has to be looked at too, we open the door for more of that innovation.
Maybe here, yes. Go ahead.
I've got the microphone.
Yeah. So it's not a question anymore. Just ask.
I'm Saeed Ibrahim. I'm
a physician at the University of Pennsylvania health system and the VA healthcare system. I straddle between those two systems. And the reason why I really enjoyed your talks because I know what's happening in the private sector. I also know what's happening in the sort of public sector. The VA, as you guys probably know, is the largest ACO in the country, even though that's not really, there's been an ACO long before the term even came into existence. But the question that I wanted to ask you guys is, how do you deal with the issue of medications? Cost is an important issue, and one of the major factors in cost of healthcare is medications, and they're becoming increasingly more and more expensive. So, what is the role of the cost of medications in Medicaid management, and how does this really play into your equation?
I can say actually both New York and us, we're doing quite a bit now with the feds and locally on some of the things we both want to do on pharmacy. Our goal as a public payer, actually for some of the specialized orphan drugs, we have the vast majority of those members because they have a disability or something around Medicaid. We want to provide the broadest access possible at the cheapest cost possible because we're a public payer. So it's as simple as that. I think we want every lever that we can have to negotiate effective rates with manufacturers, and we're asking for federal authority to do more things around that, the same way a commercial or Medicare care plan would be able to negotiate with manufacturers. There are drugs out there that have very clear evidence where you can see over time, you see great benefits, both cost and outcomes. There are others where it's harder to make that case. So that's the complexity of figuring out what to balance from a public payer standpoint. But pharmacies are our single fastest growing line item.
And it's the same in California. We're having the same sorts of problems, and a lot of it's at the federal level where the solution has to be found. And we have CalPERS, which is our retirement system, our Medicaid system, we've got our counties. We're trying to combine all of those pools to make sure that we're getting the best leverage that we can. But it continues to just go up. And I'm not seeing anything changing in the near term that's going to stop it.
Let's allow one last brief question and a brief answer. So maybe someone from the back there, near.
Wonderful talk and discussion. Thank you. I'm a practicing physician and an medical informatics entrepreneur. And I heard each of you describe various inefficiencies in the existing delivery system. And several of you also speak about issues concerning integration of data. And I was wondering, from your perspectives, managing large payer organizations effectively, what combination of incentives or regulations would you like to see happen or move forward to promote a more effective integration of information, both data integration between these large informatics systems that really now are at the sort of the chassis of healthcare delivery, and workflow integration so that data from one system can flow into the workflow and decision-making in another? How do we make that happen from your point of view?
Can we ask you guys that question? How would you make that happen? Can you solve it for us?
Yeah, I mean, I think it's one of the great challenges that each of our ACO-like entities is, and you'll hear later from IBM Watson, who is actually doing a very interesting program in central New York around Syracuse, where they've got in that market, I think there's like 36 different electronic health records, and trying to figure out how you can really pull data from those in meaningful, actionable ways, in things that are HIPAA compliant and all the challenges. And I'd say that's sort of that overcoming those challenges is one of the greatest challenges we have to achieving the benefits of integrated care. Because integrated care is not a new concept. In fact, if you go back to the managed competition days, Hillary Clinton's first versions was all about trying to achieve the benefits of managed competition. But while we have the Kaiser Permanentes of the world, that model never became ubiquitous. And I think what we're trying to do, in a great extent through ACOs, is trying to create the benefits of integrated delivery without forcing everyone into a single employed model. But in order to accomplish the benefits and the feel of integration from a patient standpoint, from a provider standpoint, from a payer standpoint, we need to figure out how to share information across these organizations in ways that are compliant with state and federal laws.
So I want to make sure that Jay will not blame me that he didn't get A because of me. So I want to thank the panel members. Thanks for the questions. I want to leave us maybe with one thought. I think that all the panel members mentioned how it's important to bring the stakeholders together, and they primarily referred, I think, to their own state, but I want to raise the question, what can we do actually to create that ecosystem across the states? Because I believe that that's one of the major barriers currently to scale innovation in the US, the fact that you have state, and each state might be a completely different story. So with that, I want to thank everybody, and again, thanks to the panel members.
Yeah.